Hello, and welcome to Health Talk, a show where we dive into common health challenges with local experts to bring you the information that you need to live your best, healthiest life. My name is Dr. Desmar Walks, family physician and local health authority for Austin-Travis County. It's August, and that means that it's Pride Month. Today, our show is all about health in the LGBTQAI plus community. As part of Austin's diverse community, LGBTQAI plus people have health concerns that the general population may not, due to a combination of social, cultural, and biological factors. For example, men who have sex with men are more vulnerable to HIV and certain STIs. Lesbian and bisexual women may have increased risk for some cancers due to lower rates of preventative screenings. LGBTQAI individuals often face chronic stress from discrimination, stigma, and marginalization, which can lead to higher rates of mental health issues like depression, anxiety, and substance use. LGBTQAI individuals who also belong to other marginalized groups may face compounded health disparities, and lack of family acceptance and social support impact their mental health and access to care. To discuss all this and more, we have two special guests on the show today. Let me introduce Dr. Mike Stefanowicz, who's the Director of Intensive Outpatient Care and Inclusion Health. He is also an assistant professor of population health at the University of Texas Dell Medical School. And Jimmy Baker, who is a public health outreach coordinator for Austin Public Health, where he works to address the HIV/AIDS epidemic, which disproportionately affects community of color. He does this through screening, counseling, and education in our community. Welcome, Mike and Jimmy.
Thank you, Dr. Walks.
It's great to have you today. Really looking forward to our discussion. You're both in positions to talk to real people in our community every day, and just like you to give us a list of some of the top health issues that you're hearing about right now. Jimmy?
So I think for me and the people that I interact with on a daily basis, it's mostly that comprehensive primary care aspect that seems to be missing, but also removing the singularity of HIV and STI only belonging to the LGBTQIA plus community. I think it's really a matter of removing those barriers, removing those stigma, educating everyone, getting our youth educated and excited about becoming physicians and doctors so that they can then represent us as well. And then also there is that our aging crowd, our elders, that, that unheard population that seems to be often missed in our outreaches.
Right, and especially since we now have so many treatments that help people age well into their 70s and 80s. Mike, passing it to you.
Sure. I would say I echo the same sentiments as Jimmy. I see a lot of the same common themes in my practice and with my patients, who I have the great fortune of taking care of. But I also want to say, I think it's worth noting, the LGBTQI plus population we know this, is not a monolith. And so, the wants, desires, needs of gay men or lesbians may be at times very divergent from the primary healthcare needs or social needs of trans, non-binary, or gender diverse individuals. And so I see a lot of heterogeneity in terms of kind of what those needs are. And I think that's worth saying. But I want to echo the same sentiments in terms of inclusive access to low barrier primary care. Mm-hmm. I think we've made leaps and bounds with access to sexual health care, but whole person primary care is a different story. And with that, really cost and the ability to pay for that insurance as well. LGBTQ plus folks are uninsured at a much higher rate than the general population. So it's a big need.
What are some of the common misconceptions that you encounter about LGBTQAI community in your sphere of influence in the medical profession, say? I think you touched on some of that just now, but if you would like to elaborate.
Yeah. I mean, and I'll speak both as a doctor who cares for a lot of LGBTQ plus patients, but also as a gay man and a patient myself. All doctors are patients, hopefully. And I think one of the misconceptions out there is that, because we're talking about LGBTQ plus populations, the needs are primarily always related to sexual orientation or gender identity. And those may be thematic, those may be defining needs for many, but that's not be all end all for many. For some, it may be family planning or starting a family, or affording transportation of their healthcare appointments, or again, just having access to health insurance.
And for you, Jimmy, in the public health realm?
Yeah, and honestly, I feel like we're gonna be echoing each other a lot this interview. But especially there was one thing about us not being monolithic. I think too, also within the public health sector, is that I tend to see a lot of programs that obviously focus on sexual health among the LGBTQIA plus. I'm just gonna say queer to kind of. I'm just around the queer community, but also the absence of those people in those programs and in those planning and in the development of those things, I think plays a bigger role in like the missed opportunities that exist among us. And this is just from a public health department standpoint, employee standpoint. I don't speak for APH, by the way.
Nothing about us without us, right?
Mm-hmm.
How often should listeners get tested for HIV and STIs? And I'm saying this in general, not just for the LGBTQ plus community.
I would say the answer is, with all things related to healthcare, kind of depends, right? We don't want to necessarily be too prescriptive, because it's really what's right for an individual. And so I would say at minimum, everybody should have an opportunity to test for HIV at least once in their lifetime, with the whole cadre of other STI tests available too. I think too often in healthcare we see people getting piecemeal testing, maybe an HIV test but no syphilis testing, or an HIV test but no counseling on their sexual health and wellness. And so I really want to paint a holistic picture for people in the community, advocate for really what should be comprehensive wellness approach to sexual health. Mm-hmm. So at least once for all STIs over one's lifetime. And if you're choosing to be sexually active, or if you have a new partner, I would say it's always a good opportunity to get tested at that time as well.
What's been your experience with what's actually going on when you do outreach out in the community, Jimmy?
It's a little bit of everything. If we're being honest, we definitely see people. We have our consistent people who come once a month between every partner. We have first timers. We have people who, get tested because there may be an exposure or something like that. And so with me, I always say, like, if you just had sex raw with someone that you don't know their status, and it was just a sweet conversation, just go get tested. That's my honest recommendation. I mean, we follow CDC 3 to 6 months, but absolutely, I say in between every partner, just because I know that there are resources within the city, and being a resource for those people, I think, is what's prominent for me.
Thanks. What are the current recommendations for HIV prevention, particularly speaking to PrEP and PEP?
The nice thing is, 2024, we've never had more opportunities to prevent HIV than we have today. And so I like to always paint a picture of a toolbox, of which PrEP, pre-exposure prophylaxis for HIV prevention, is one. That could be a daily pill. That could be a long-acting injectable medicine. And there's other new longer-acting injectables coming down the pipeline, which are really exciting. But that's one tool, right? PEP, people can take it if they've been exposed to HIV within 72 hours. But I also want to acknowledge there's plenty of other tools beyond those therapies. Condoms are tried and true, and they reduce the risk not only of HIV, but other sexually transmitted infections as well. Knowing your status goes a long way, and engaging with your partners on really honest, candid conversations about their sexual health history as well, I think is a really great way to break this cycle of stigma around sexual health and demystify it a little bit.
And again, just to go back to what we started with in this conversation, and that would apply to men and women, right? What you just said.
Oh, absolutely. Absolutely. I think if you look at, I'm not going to delve into the weeds on the numbers too much right now, but if you look at the breakdown as far as HIV transmissions, I think the general public, there's a mindset that most HIV transmissions are occurring amongst gay men. And about 2/3 of new infections. That is true. But in terms of heterosexual individuals, about 15% are women. There's 15% are women and 7% are men, actually. So twice as many heterosexual women as men acquiring HIV more recently. So PrEP is applicable to them as well.
Can I add something to that too as well? Because I wrote my I wrote my practicum on that. I also too with the DL myth, and I really like that is a common misconception is that like DL men are the primary cause among HIV with heterosexual women. That is not the case at all. It's actually been found that DL men account for a very low amount of transmission rates among heterosexual women, and I think we need to like really express that and like let that be known that like the whole ideology behind the down low phenomenon, it was just like a myth made up to kind of like justify that HIV or GRID was a gay man's disease back then.
Mm-hmm. Thanks. And so moving on to another really prominent illness that we're seeing in our community, syphilis. We just had DoxyPEP approved by the CDC. We've gotten the final guidance on that. DoxyPEP is something that will prevent syphilis. Can you give us more information about that, Mike?
Absolutely. It's really exciting, actually. And again, it's 2024. We've never had more tools in our toolbox than today to prevent not only HIV, but other sexually transmitted infections. And so, DoxyPEP is essentially doxycycline. It's an antibiotic that's been around a long time. It has a lot of other uses, like all their antibiotics. And recently it's been studied in the context of, well, what if I take 2 pills after a sexual encounter with a partner, a condomless sexual encounter? And what the data showed was that if you take 2 pills, 200 milligrams of doxy within 72 hours, sooner the better, of a sexual encounter, it really has a profound effect on reducing your risk of actually converting to an active syphilis, chlamydia, and to a lesser degree gonorrhea infection. About 70 to 80% real world data for chlamydia and for syphilis, and actually a little higher even in one of the studies, and then about 50 to 60% for gonorrhea, which again, when paired with other risk reduction strategies, I think can have a profound effect in our community.
What questions do you see coming up with that new tool in the toolbox, Jimmy, as you work with clients out in the community?
Yeah, our biggest question is always, where can I get it? We've had encounters where we've gotten stories where providers aren't knowledgeable about DoxyPEP or even willing to prescribe it. So typically we always, refer to our ASOs and our partners, our lovely Dr. Mikes and everyone else, and just pretty much also encourage our patients to kind of do the work yourself, do a little Google, get some peer reviewed research done, and present that to your doctor to kind of like help and make an informed decision for your own, kind of be your own self advocate too.
So just going back to talk a little bit more about syphilis, other STIs, the incidence of the other STIs has remained relatively flat. Why do you think, or what do you think is impacting the increase in syphilis that we've been seeing in our community, Jim?
I think for me, it's mostly a lack of knowledge revolving around how much should I get tested, what are sexually health practices. It's more than just, hey, when's the last time you've been tested? And, really having those in-depth conversations. I personally, in my interactions, I've seen that they just aren't happening, but that just also that sexual health isn't as promoted as much as it should be. Just really encouraging those interactions, encouraging treatment, encouraging getting tested, and having access and knowledge of where you can get tested matters greatly, if you ask me.
What about for you, Mike?
I would say, for syphilis right now, if you look back from 2018 to 2022, it's about an 80% spike nationally. And that's spilled over into cases of congenital syphilis, transmission from pregnant parent to child. It's which can be devastating. And so it really is it's one of the great public health challenges, I think, of our time. And it's kind of gone silent for a little while. And, if you look back 2 decades ago, we were almost on the cusp of beating syphilis, whatever that means. But, I would say that access to testing has been limited for some. people's sense of who needs to get tested. I think some of the guidance for clinicians on who to test can be a little muddled, a little confusing at times. And so that's why I think for the community, I love to keep it simple. If you're going in there for an HIV test, you should ask your clinician about getting the whole gamut of testing. We know co-infections occur at a really high rate. And we know that things like syphilis and gonorrhea are really canaries in the coal mine for future HIV acquisition 6 to 12 months later. So it's a risk marker for us. So I think all of those things together, we're really, in terms of medical science, also just having access to testing that's a little bit easier to interpret, right?
Mm-hmm.
So gonorrhea or chlamydia, it's usually positive or negative. Mm-hmm. Syphilis testing as a doc, it could be a little harder to interpret at times, especially if you're a doc who doesn't do that day to day.
Mm-hmm. And as you talk about co-infections or the incidence of people having more than one STI infection, there's Mpox that we've seen. We saw that outbreak in Mpox that happened in July of 2022, and that public health emergency that was declared by the WHO ended in May of 2023. But hot off the press, Dr. Tedros, the Director General of the WHO, 3 or 4 hours ago, declared Mpox as a public health emergency again. And that was based on an increase in the number of cases over in Africa, in the DRC, Democratic Republic of the Congo, and spread due to travel into some of those surrounding countries. So we know that our 2022 outbreak that we had here in the U.S. happened as a result of travel, and I think it would be good for us to talk a little bit about Mpox and what we know about that, and what the experience has been about what people know in the community, Jimmy, about Mpox.
So with us, as far as people in the community, I think it's the biggest misconception is that it's mainly gay men acquiring a disease. It's a STI, which it is not. And I think also is that, once again, it's that monolithic ideology of an entire community that is perpetuating homophobia, racism, all the isms that affect us on a daily, you know what I'm saying? And all of that is constantly just barging down on us. And so it just makes it hard for access. It makes it hard to talk, and it makes it hard to just have those real conversations. Mm-hmm. Because I think that's what's going to open the door to really figuring out, not necessarily just the Mpox disease as a whole, but just how can we fight this? You know what I'm saying? It has to become bigger than what we're dealing with.
And that's a really great point, because in Africa, where it's been endemic, it is affecting both men, women, and children. And so can you speak a little bit more about what are the signs and symptoms? How can we best keep that from affecting people in our community?
Sure. Mpox historically has really 2 different clades or groups of the virus, and they present a little differently from one from the other. The Mpox clade that is really run through the United States is really a little bit less, to use a medical term, virulent in terms of its severity and mortality. So there are fewer people who died from Mpox-related disease here in the U.S. But the symptoms can be sometimes a little subtle, and they can vary from what we're accustomed to looking at in textbooks, or certainly if you Google it right now, I think you'll see a lot of those really severe-looking cases that can be a little easier to miss if you go into your general PCP's office here in the United States. And so the major symptoms to look out for really are, you can be exposed, and there could be a long incubation period, anywhere from about 3 to 17 days or so, meaning you may not have symptoms for quite some time. Symptoms can start with fevers, they can start with night sweats, they can start with flu-like symptoms, rash. Some of the bumps that are characteristic of Mpox can occur at the sites of infection or at other areas of the body, and they can spread rather easily after that. And so the most important thing I think for people to know is if you have symptoms and you're concerned and you may have been exposed, it's really important to actually reach out to your healthcare provider or other great organizations around town like Austin Public Health as soon as possible, because it's important to get tested and to notify those partners. And some may be eligible for other treatments as well.
Right, to prevent spread and prevent developing the disease, and also to help with identifying this. I think we need to put a real pin in the statement you made earlier, which is if you're testing for one STI, ask for the whole complement of tests, because there's some great mimickers. Mpox is something that can mimic syphilis, for instance, or other types of STIs that we see. I think moving on from STI and our discussion about that, smoking is something that we've talked about in the medical profession for many, many years. And we're still seeing a large impact in the LGBTQ plus community. So can you tell me, Jimmy, what you're seeing in the community and why there may be a resistance to smoking cessation?
Yeah, honestly, I think I'll say this personally. I did the math this morning when I saw this question. I was at $617.32 since January because I vape.
Mm-hmm.
And it's sexual minorities are naturally inclinated to, I shouldn't say naturally inclinated, are more likely to smoke. And so it's those stressors, and it's that kind of like that escapism that like we crave and we look for from a world where we're just constantly berated on and constantly looked down upon. And so when we with every outreach with us, every patient gets a smoking cessation questionnaire, and it is asked, would you like services? And most of the time it's always no. And it's because it's usually, I got enough going on, I ain't got time to be giving up cigarettes. And you can't fight that. You can't fight agency. It's kind of, I understand, and you let them go.
Mm-hmm. So true. But I think asking the question is really valuable, because maybe one of those times you ask, it might work, correct, Mike?
Well, absolutely. I ask every time, irrespective of the patient. And I've been a physician in practice for a few years, but it took me about a good 12 or 13 years to actually stop smoking myself. And so it was only around medical school, actually. And I have a lot of memories of as a young gay youth in the bars with the Marlboro folks handing out, freebies all the time. And it really just goes to show you that also that as a matter of health policy, tobacco companies have classically, they've had a predatory approach to minority communities, including LGBTQ plus communities, actually. And there's a long historical kind of thread there, not just with LGBTQ folks, but others.
And I think you're so correct in that, because it took me a long time too, and stress does have a lot to do with it. And being asked several times, one of those times it worked. So yeah,
I was Newport 100s in a box.
What would you say are some of the unique concerns of transgender individuals, especially regarding hormone therapy and or surgical intervention?
Okay. I think for our transgender individuals that we serve, I think mostly too is just having comprehensive providers who understand that for trans men who may not have had bottom surgery, you still need gyno appointments and things like that, or like you said, lesbian women. Sorry, we're talking about transgender people, but also mammograms and things like that may be done when you don't have those surgeries, but providers aren't encouraging that or pushing that for our transgender individuals. I think that plays a major hand of not having that provider that can be that sounding rock for you. And I think that the limitation of those providers has made a big difference in the access of care for our transgender brothers and sisters and people.
Oh, absolutely. Because adapting best medical practice for trans, non-binary, and gender diverse patients in the clinic is one thing, but upstream we have a huge lift in terms of cultivating the trust of that community to even create a welcoming, inclusive space where they want to come get care.
Mm.
There was a really good eye-opening survey, about 90,000 trans folks in the US, 2022. 1 in 2 said they experienced healthcare discrimination by their healthcare provider in the last 12 months, which is really eye-opening. And that included discrimination on the basis of refusing to respect their pronouns, refusing to refer them to specialists for gender-affirming care. And so I think the care is one thing, but cultivating an inclusive, welcoming environment for people to get that care is a whole nother story. We have a long ways to go.
Yeah, this conversation hopefully will be a way for people to advocate for themselves too. For our listeners who may be struggling with advocating for themselves, how would you suggest that they discuss their sexual health openly with their healthcare providers?
Well, baby, you got to find a provider you trust. To be perfectly honest, I lucked up with my provider, who is a queer man, and so he gets those nuances. And I will say he is a cis white queer man, so there are some differences between our cultural lifestyle that he may not understand, that I may have to educate him on, but there is never a moment where he isn't willing to be educated on. And I think you have to like kind of shake that God mentality out of your physicians and like, girl, no, this is my life. You may have learned this in school, but at the same time, you don't know what I'm going through on a daily basis. And I think also too, it's beyond just being comfortable with your physicians, being comfortable with your friends, being comfortable with your family. You have to have those sexual health conversations just in almost all aspects of your life. You know what I'm saying? Like, because, you may be like me, having to talk to your nieces and nephews now all of a sudden about like having sex, and I'm like, where are my brothers and sisters? You know what I'm saying? And so, yes, I think it's an expansion and just learning and really finding those experts, those people that are willing to have those conversations with you so that they can model what a conversation may look like for you in a different space.
Thanks.
I mean, I spend a good bit of time every day teaching kind of the next generation of medical students and residents. Something I always tell them is, it's not your patient. While you may learn a lot of great things from your patients, it's not your patient's responsibility to teach you. They're there first and foremost to get good care from you. And so I think when it specifically applies to gender diverse and sexual minority groups, they're there for a reason. They're there to get care. It's not, the onus shouldn't be on them to spend the bulk of their visit to educate their clinician. It's incumbent on us. Medicine's always changing, right? It's never static, and that's a good thing. It's incumbent on us to evolve, and it's incumbent on us to learn the latest in terms of terminology, learn the latest in what it means to create an inclusive health space for folks. So I think we both kind of turned that question on its head, and that what is it that patients can do to advocate for themselves, but really it's what can we as a health system do to make a more inviting space for patients.
I would agree. Just quickly before we wrap up, how can listeners find healthcare providers in Texas that are providing care in a culturally appropriate manner to the LGBTQ plus community?
My first go-to is always Quell. They have a beautifully comprehensive list that breaks us down through all of the intersectionalities. But then also HRC is a great resource as well. Your local health department, we have access to a lot of providers as well that we work with that are culturally competent too. And then also too, just talking to your community, if you have community, if you have those friends, where do you go? Who do you see? And making your decision from there.
That's all the time we have for today's episode of Health Talk. Thank you to KAZI 88.7 and to St. David's Foundation for their support of this program. Until next time, take care of yourselves and each other. This is Dr. Desmond Walks signing off. Be well.